Hello, thank you for joining us here today. My name is Jessica Merritt. I'm the Director of Business Development here at Hudson Alpha Institute for Biotechnology. And before we get started, I want to go ahead and thank Mark and Russ for having us again this year at Health Connect South. Today, I've got some brilliant people with me, and we're going to talk about how precision medicine is transforming treatment for oncology and neonatal patients. But before we get started, I want to give an introduction of Hudson Alpha. So I know a few of you know us and have seen us at previous year's conferences, but I know we're going to be new to some of you. So first, let me introduce ourselves. So Hudson Alpha is a nonprofit genomics research institute located in Huntsville, Alabama. So we're just a short drive away from our friends over there in Atlanta. And for over 13 years, our scientists have been applying the power of genomics to make advances in human health across the globe. We have collaborations all over the world. And we don't just operate in the research space, we're also very much in the clinical spaces too. And I know a lot of you here in the audience are really focused in the clinical space, and that's where the majority of our time will be spent today. But our key focus at Hudson Alpha is really translating the power of genomics into real world results. So going back a little ways, we opened our doors in 2008. And our founders really envisioned an institute that would make discoveries in the lab and quickly spin those out into for-profit companies to really speed the pace of innovation and deliver solutions into the hands of clinicians and patients more quickly. So our research lab, I do want to talk a little bit about the research that goes on here. They focus on everything from rare disease, neurological diseases, cancer genomics, epigenetics, as well as plant genomics. And we have a beautiful campus here in Cummings Research Park, which is actually the second largest research park in the nation. And we have over 45 companies located here on our campus. Most of these are in the genetics and genomics space, but all of them have ties to what we do here at the nonprofit. So again, today, what we're really focusing on is our genomic health program and what this can mean to our collaborators and partners. This is our third year presenting in this conference. So previous years, in 2019, we focused on a collaboration with Auburn University and how we were bringing pharmacogenomics to their employees at the university. Last year, we highlighted a collaboration with East Alabama Medical Center, where we really talked through some of the outcomes of what was seen when they tested their health system employees, different outcomes that they saw. So shifting gears a little bit, where we're focused now is really helping health systems and providers offer precision medicine programs to their patients and their health systems. So with that, our talk again is how precision medicine is transforming the treatment for oncology and neonatal patients. And so I want to introduce those brilliant people I mentioned before. I've got Dr. Devin Absher here. He is a faculty investigator. He is the Director of Genomic Health here at the Institute. And I also have Dr. David Bick. He is a clinical geneticist. He runs the Smith Family Clinic for Genomic Medicine, which is a rare and undiagnosed disease clinic. And he's also the lab director at the Clinical Services Lab. So Devin, let's start with you. Can you tell us a little bit more about yourself and about your role here?
Sure, thanks, Jess. I'm a faculty member here at Hudson Alpha. I run a research lab with a focus on genetics and epigenetics of complex human diseases, things like cardiometabolic traits and diseases and autoimmune diseases. And as you mentioned, I'm also Director of Genomic Health. The Genomic Health program here at Hudson Alpha really encompasses all of our clinical interests. It includes the clinic that Dr. Bick will be talking about, the Smith Family Clinic for Genomic Medicine. It includes a clinical lab, the Clinical Services Lab, a CLIA CAP lab with a focus on genetics and genomics laboratory assays. And it includes the Health Alliance, which is a partnership program that we've established to help bring the expertise we have here on our campus to our partners. And those would be health systems, physicians, and even employers who are doing genetic testing. So our mission in the genomic health space is really to enable the use of genomics in clinical practice and to really expand access to precision medicine in a variety of clinical settings, not just in major academic medical centers where it's often practiced, but also in community regional health systems, rural health systems, and just about everywhere else where patients need access.
Wonderful, thank you. David, you're up. You want to share a little bit about
Sure.
yourself and your roles?
Yeah, Jess. So I'm a clinical geneticist. So I've been practicing for about 30 years, but I'm also a laboratory molecular geneticist, and I've been involved in laboratories for also many, many years. I came to Hudson Alpha about 6 years ago, actually to really help move whole genome sequencing out of the laboratory and into routine clinical practice. And in fact, that's why we started the Smith Family Clinic for Genomic Medicine. It was a wonderful contribution by the Smith family. And what we were doing there, or what we have been doing all of this time, is we said, all right, here is how genetics is typically practiced. We'll see a patient, we'll take a history, we'll do physical exam, take a family history, and we'll try and sort out what rare disease they have. And all of that information is extremely helpful. And there are a number of genetic tests which are readily available through commercial laboratories that can help us with many of the patients. But there's always a group of patients that are sort of a head scratcher where we say, well, gee, if we could just sequence the entire genome, we might be able to turn up an answer that we can't in the usual ways. And sure enough, that's what we've been able to do in this clinic. We're able to deploy whole genome sequencing in that setting as an additional test when needed to really sort things out. And it has turned up some remarkable diagnoses. So that's on the clinical side. We also have what Jess had alluded to, our clinical services laboratory, where I'm the director currently. And we provide whole genome sequencing as a clinical test. But in addition, as Devin alluded to, we've added some other very important genetic tests, which are becoming much more widely used. These include things such as pharmacogenetics, pharmacogenomic testing, which is used by health systems and companies actually to help with their employees, to help them with their own medical care. So that's been a benefit to those companies. And also we've added oncology testing because we know that there is precision medicine as a way to help select treatments. And I know Devin's going to talk about that some more. I guess one thing I always like to chat about is, well, how did I even come to whole genome sequencing at all? Well, it turns out that prior to my time here at Hudson Alpha, I was at the Medical College of Wisconsin. And around about 2009, I believe, there was a child who had a very severe form of Crohn's disease, and nothing really seemed to be helping the child. It was clear that no one really knew what was going on. And so it was proposed to sequence all of that child's genes, and it turned out that the child actually had an immune condition. And then once that became known, a bone marrow transplant was performed, and that actually cured the child. And so that was really the first case in the United States where it became very clear that genomics was going to have a major role to play in healthcare. And actually in 2010, not long after that child's case, the Children's Hospital started or funded a large clinical program where we were the first to initiate whole genome sequencing as a clinical test and also a genomics medicine service. And so all of those things got started. And I came to Hudson Alpha because I knew here I could expand on what we had started, both in the clinic and in the laboratory.
Wonderful. Thanks for that great background, David. Okay, so we have a lot of ground to cover today, so we'll go ahead and jump in. So Devin, can you share a little bit about the current landscape of precision medicine and why it's important to expand equitable access to these programs?
Certainly. So I think of precision medicine and genomic medicine specifically, really in two contexts. There's the types of institutions that are active in these areas, and then there's the type of clinical care in which they're being deployed. So if you think about the clinical side of it, there's really three realms that we've already been talking about. There's precision oncology, in which tumor samples, tissue from cancer patients is being sequenced to try to direct care for those patients in the most appropriate way based on the mutations that are present in that tumor. There's also rare disease diagnostics, as David has been saying, it's really an extension of the field of medical genetics that has been going on for decades, but that has really been enabled by new technology like whole genome sequencing. So that's another space. And then there's population screening, really attempts to use genomics to sort of predict future outcomes for patients. And that could be pharmacogenetics, where you're doing testing in otherwise healthy people. So it's not a diagnostic test per se, but it's a test that will tell you, in many cases, what the most appropriate medications are for a given patient and which medications they may not be metabolizing that they're currently taking and may consider alternatives. So that population screening area might also consist of things like heritable cancer screening, right? Sequencing BRCA1 and 2 genes in order to predict who might be at highest risk for cancer. It might also include things like polygenic risk scores that people are very excited about for the common complex diseases that I tend to work on, how you might predict the patients who are going to be most likely to have heart disease or diabetes down the road. So there's those three spaces in which genomics are currently being applied in clinical practice. From another angle, you can also think about the institutions that are practicing some form of precision medicine or genomic medicine. And for the most part, the big academic medical centers are the places where these activities are happening the most. And that makes the most sense. That's where the expertise tends to be. That's where there's a motivated set of clinicians, often physician scientists who are well-versed in the science behind it, the technology, and they're comfortable using genomics for their patients. Less so is the use of precision medicine in other clinical contexts, right? So regional health systems, community health systems, rural health systems are not yet involved in a big way in a lot of these areas, right? And they may be involved in some, but not others. Like you'll often see cancer centers, regional cancer centers, they are pretty mature in their use of genomics. So they might be using some sequencing of tumor material to try to guide therapy for their patients. But they may not be doing pharmacogenetics or other heritable cancer tests. And other health systems may not be using the latest and greatest whole genome sequencing for their rare disease patients in a way that other big academic medical centers are. So there's a real need, we think, in expanding access, really enabling other clinical settings to adopt genomics in their everyday clinical care. And to do that, of course, they need access to the types of expertise, the types of technology, the IT solutions, the laboratory solutions, everything that Hudson Alpha really focuses on, that our genomic health focuses on. They need access to some parts of all of that to really stand up a precision medicine program. And so our goal is really to enable those that don't have that expertise to gain access to it. And that means probably a diversity of different programs. Sometimes it's everything. So as I mentioned before, we have the Hudson Alpha Health Alliance is established to make these partnerships work. In some cases, that means everything from educating and engaging patients who are going to be getting genetic tests, all the way through to educating and engaging the physicians who are going to be ordering those tests and providing them with the clinical decision support that they need once those test results come back. Because we all know that the clinicians, in many cases, have varying degrees of comfort with some of these genetic tests and how they're best used. And they really are looking for honest brokers, right? Because there's a lot of companies and laboratory tests out there and not a lot of knowledge about what the most appropriate use for those tests are and what the limitations of those tests are. So we feel as a nonprofit, we are well situated to provide these suites of services, laboratory services, clinical support services, education and engagement, all the things that will make these programs work, and also be somebody who's on the side of evidence-based medicine throughout the whole process to make sure that the clinicians get the best advice possible when they're utilizing this data.
Wonderful. Thank you for that background. I know a lot of different health systems are on different paths. Some of them are further along than others, but I appreciate you pointing that out, that there's an opportunity without standing up your own program. Sometimes you can send out, it's looking for those honest broker partners, making sure you can gain access. So we'll dig in a little bit more into the specific fields of oncology and neonatology, but let's go ahead and start with oncology. So Devin, can you share a little bit more about the field of precision oncology, what clinicians can learn by implementing this precision testing into their practice?
Absolutely. So as I mentioned, yeah, it's one of the more mature areas of precision medicine, perhaps, because I think oncologists, maybe more than other specialists, are more comfortable using genetics in some way, and they have been for many years. Ordering sequencing of certain genes for certain cancer types to sort of identify the most appropriate therapy for their patients. So in some respects, it's a little bit further along in some of the other areas in terms of clinical adoption. But what's been happening lately is the push to build bigger and bigger cancer panels or more comprehensive analyses of tumors. So while in the past, oncologists might order the sequencing of 1 or 2 genes, maybe 5 or 6 genes that they think are the most relevant. There's now growing evidence that interrogating a wide variety of cancer-relevant genes has a huge impact on how cancer patients are treated. So one example of that is things like tumor mutational burden and microsatellite instability metrics that will inform how some patients might respond to immunotherapies, for example. So that those kinds of pieces of information really only come to the clinician if they're going to use more comprehensive tests. And so what's exciting is that it's because next-gen sequencing has become less and less expensive, it becomes more of a viable option for a cancer patient's tumor to be analyzed with a broader set of genes and a variety of different analytical approaches in order to find the right therapy for that patient. So in our clinical lab, in the clinical services lab, we offer both a 500 gene panel and a 170 gene panel specifically for solid tumors, both of which are really good at detecting, the variants in all of the most relevant cancer genes that people typically sequence, but also it sequences RNA in a way that enables you to detect gene fusions, which are often difficult to detect by other methods, all in one assay. And then, as I said, getting metrics like tumor mutational burden and microsatellite instability out of the same assay. So we think that those approaches are going to become more of a first-line test rather than these sort of stepwise sequencing of smaller panels of genes in an effort to find the right therapy. And as we all know, in the cancer space, getting the patients on the right therapy the first time is critical to their outcomes.
Wonderful. I do have one more question on that. So related to precision oncology, let's say there's a health system that, maybe has dabbled in this a little bit. They aren't focused too much in this space. They want to go down this path. They team up with a partner, whether it's us or someone else. What types of expertise would they need to have on the ground? Do they need to have a molecular pathologist there at their health system? Are there options where they would just send a sample somewhere else? That part would be done elsewhere. What does that look like on the ground?
Yeah, that's a great question. There's a real art to the pathology side of this, where if you are going to sequence material from a tumor and you're going to detect low frequency somatic variants in that tumor sample, you really need to be careful about what you're sequencing. So there's a big role for pathologists to play in this process, in which They actually do microdissections of tumor material off the slide, and we sequence that material as a way to really drive the sequencing assay towards the tumor-specific genome. So that's a critical part, and what we do and what I think what other people will find is that they're going to get better data when they do that, rather than sequencing an entire tumor slice all together without any of that microdissection. So that process obviously adds a couple days to the workflow, but we think it's really valuable because the data that comes back at the end is going to be much more precise and accurate. So that means that everything that we sequence goes first to a pathologist, a trained molecular pathologist who knows a lot about tumor biology and can do those microdissections and provide our lab with the material that's most important to sequence.
Okay, wonderful. I just wanted to be sure, some groups may have that pathologist on staff and a lot of them won't. So it's good to know that that can be taken care of throughout the solution. So David, moving on to neonatology, but before we do, is there anything you'd like to add related to precision oncology?
No, I think the only thing I would add really is that just to emphasize what Devin has said, is that oncologists are really coming to use this molecular data, and these kinds of assays that we've launched, I think, are really becoming more and more standard around the country, because the notion of sort of doing one molecular test and then doing yet another molecular test and then following it with another one, it's sort of not practical in the time frame that you need to treat patients. And so you really want to gain all of the relevant molecular information, in the first few days, if you possibly can, because you want to design and deploy a treatment for that patient with the tumor really quickly.
Okay, thank you for adding that and bringing more focus there. So switching gears a little bit. So neonatology is an area that is beginning to embrace precision medicine a little bit more frequently than it was in past years. I know oncology is a little bit ahead of the curve there, but now we're seeing a shift in the neonatology space. So David, I was hoping you can tell us more about the different types of testing that is available, when neonatologists and health systems might want to think differently about how they approach some of the difficult cases they see, and what might trigger them to think this could be genetic and maybe I need to go down this path.
Right. So those are all very good questions. So just to start off, neonatologists have faced for many, many years this problem of the sick newborn. And a child will come into the nursery, and sometimes it'll be pretty clear what's the matter. They'll have a cardiac condition, or they'll obviously have some other, recognizable phenotype which sends them down a particular road. But there are a number of children who become sick pretty early in their course of life, in the first few days, and it's just not clear why they're ill. This is obviously incredibly stressful for parents. The neonatologists now run into a huge management problem of, well, we can sort of keep the child alive, but what specific treatment could we do that can ameliorate the problem? And these children are, in addition to how upset the parents are and how difficult it is for the neonatologists, the health systems themselves and the insurers, these are very expensive issues. Now, the other thing that I think everyone is generally appreciates is that the bulk of genetic diseases, severe genetic diseases, really actually do present in the newborn period or even in the first few months. And so that's a time when pediatricians and particularly neonatologists find themselves in sort of an acute situation. And the challenge is that there are many, many, many genetic diseases. So if you have a geneticist at your elbow 24/7, that's great. But if you don't, then you're having to do the best you can with what you and your colleagues know in your newborn setting. What's interesting is that the number of treatable genetic disorders has increased rather significantly over the years. In fact, by one count, there's about 650 childhood onset genetic disorders for which there is a very specific treatment. And more than 400 of these actually can occur in newborns. And the reason I know that is because I put together the list, and it's actually on a website, rx-genes.com, it's freely available. But the point here is that neonatologists find themselves with a very serious problem. There are these now hundreds and hundreds of treatable genetic disorders. So which one is it? And here's where rapid whole genome sequencing has come to be a valuable tool. There's a group out in California that started doing this very heavily, but a number of groups, including ourselves around the country, have started to offer this as well. It is absolutely critical for a number of these conditions that you actually figure out what the child has if you want to prevent permanent damage. And I'm going to talk about that in a moment. When we get a sample, if it arrives on a Wednesday, we'll actually have a preliminary result that following Monday morning. And so that really is a time frame when neonatologists can intervene with specific treatments that can actually be life-saving. I like to use the example, there was an article in the New England Journal of Medicine recently put out by the Rady Children's Group, where an apparently healthy 5-week-old came to the emergency room was basically in status epilepticus. And this couple who had this child had a previous sibling of this child had died at 11 months with an epileptic encephalopathy. And so the parents were sort of assuming, oh my goodness, we're going down the same road again. This child's just going to die. It's going to be terrible. But what they did was they did a rapid whole genome. And in a very short period of time, they were able to figure out that there were mutations in a gene called SLC19A3. Well, okay. Why is that so important? Because it turns out that gene and the genetic defect in the child was an abnormality in what's called thiamine metabolism. And so what they did was they very rapidly started giving the child thiamine and biotin. And within a few hours, the child was entirely well. And in the follow-up following that, the child has been well ever since. And so they turned what could have been a complete tragedy into really a very positive outcome and a child who's entirely well. And we ourselves have actually started to do this rapid whole genome sequencing. There's a case that I think of from the local hospital here where the child was born, was very hypotonic, very low tone, and was actually ventilator dependent. And so the physicians were not sure of what to do. And so we did this rapid genome sequencing, and unfortunately, we found a disease that was not treatable. It's a gene called RYR1, which causes a lethal myopathy. And whereas this is certainly not the kind of outcome we would like for the parents, it made a big difference because there was a suspicion that the child had something that was not compatible with long life, and this really proved it. So the parents were able to withdraw care, understanding exactly what had happened. And so this made a big difference to the parents, but obviously made a big difference to the neonatologists and that hospital per se. And these anecdotes really are, as I say, just sort of anecdotes of things that we've done and others have done. But now a literature is actually evolving and appearing, which is looking at this use of this technology, this rapid genome sequencing, in a more systematic way. And again, it was the group out at Rady, and they had done a study of 184 infants. And in 40% of the cases, they were able to make a diagnosis, which is rather remarkable. But from the insurance point of view, and this is critical, 32% of the cases, 32% of that 184 had a change in management due to figuring out what gene was mutated. And so this gave them information about what we would call clinical utility. In other words, changing the outcome for the child. And this is critical for insurance companies, which I will say are increasingly embracing this whole genome sequencing. So for example, out in California, the Blue Cross Blue Shield out in California, this is now a standard orderable test. You don't have to get special permission from the insurance company. It can just be ordered. The other interesting piece from this paper, and this paper came out in July of this year, is that they were able to demonstrate a cost savings of between $2.2 and $2.9 million in those 184 patients. And so the clinicians who care about the clinical utility were very excited. But in addition, the insurance company saw that it would improve outcome and save money.
Win-win. Okay, thank you, David. You clearly have a great deal of experience in this space and implementing precision medicine solutions into clinical practice here in the States. And you've been with us for, I guess, a little over 6 years now, but you are about to embark on a new venture. So can you tell the group a little bit about where you're going and what you're going to do? It's quite exciting.
Yes, this is a very interesting new phase of my life. So the British government in the last few years has gotten heavily involved in genomics. And a few years ago, they put together an advisory panel to look at the question of using whole genome sequencing as part of their newborn screen. So England, like all developed countries, has been doing the heel stick to look for a number of hereditary conditions that are treatable. The example everyone uses is PKU, or and where you would want to decrease the amount of phenylalanine that the patient was exposed to. So they said, all right, let's convene a little board to look at this. And I was part of that board. And it was felt that it might be a good idea to try out whole genome sequencing as an addition to the routine newborn screening panel. And so that's in fact what I'm going over to England to do, is to help work with them to develop a program by which whole genome sequencing would be used on every child born in England. And so it's quite an ambitious project. They have many hundreds of people and the entire health system working on this project. So I'm hoping I can help them move it along quickly. I will say that in this country, there are 3 states that are planning to do this. California, New York, and Utah are all planning to use genomics to supplement their newborn screening program in exactly the same way.
And do you know when they're planning to do that?
So I do know from my colleagues in California and New York that within the next year, I think they're going to be launching pilot programs, and the program in England is obviously a pilot program, but their idea of a pilot program is 200,000 newborns, which is sort of a larger than pilot programs that I've been involved in. But California, Utah, and New York are all initiating pilot programs to do exactly this, because if you know that there are 650 treatable disorders, and you know that 400 of them can appear as in the newborn period, then your ability to intervene before the child becomes seriously ill for those 400 conditions is an enormous step forward.
Truly. And so one last question on that. So in those 3 states here in the States that are looking to do that in, the near future, who is leading that charge?
In each state, it's different. I'm pretty sure that the Rady Group out in California is leading the charge there. The New York Genome Center is leading the charge in New York State. And in Utah, I believe it's the state screening laboratory itself, which has initiated this. Naturally, in all three of the states, the state screening lab is very heavily involved in the whole project.
Okay, thank you. Okay, so shifting gears a little bit, I think all of us here on this call, hopefully some in the audience too, can agree that implementing genomics and precision medicine into practice is beneficial on multiple fronts. But it's also important to point out that there are some barriers here and things groups need to think about before going down this path. So Devin, are there a few things that you can share about what those barriers might be and how they might be overcome?
Yeah, for sure. There's obviously a great deal of diversity in terms of the level of expertise that different health systems have, whether they have, genetic counseling on staff, whether they have medical geneticists on staff, whether they have people who understand pharmacogenetics and can provide the necessary support, whether they have a lab that can run, complex genomic assays. All of that will play into a decision about who you might partner with to fill those gaps if a health system doesn't have them. I would say that, for most of the spaces that we've been talking about, what people often don't realize is just how much engagement is necessary of both patients and physicians beforehand. Simply ordering tests, ordering genome tests, and throwing, 40-page reports on the desks of physicians is not going to solve any problems. It's probably going to create more problems than it solves if you haven't prepared the groundwork for that. That means engaging the clinicians ahead of time to be prepared for that, making sure that they are aware of all of the clinical decision support that can be harnessed, all of the clinical guidelines that they're going to have to review before they act on that data. Consult services, how are those going to be arranged if you don't have genetic counselors in your system? And there are plenty of areas of this country where genetic counseling is at a premium. There just aren't enough genetic counselors to really serve the need. So what we often see in many of our partnerships is that depending on the level of expertise that exists already on the ground, that will, in many cases, determine both the success of precision medicine programs and the extent to which places like Hudson Alpha can really help. So because we have sort of this full suite of end-to-end solutions for a health system, we can provide the parts that make the most sense. Everything, education is one of our mission areas. We didn't talk about education, but our educators and our genetic counselors have developed content to help people understand genomics broadly, the general population. And that same content, those same materials, educational materials, can be used for patients, for family members, anybody who's getting genetic tests, so that they can understand it better when they're about to receive a test result or they're considering a genetic test of some sort. And those same things can be used with clinicians, with physicians and nurses, nurse practitioners, and people who are going to be ordering these tests and getting them back and helping to understand exactly how they're applied. So it's really that all the support parts that I think people don't appreciate. They think it's just a matter of getting a lab test run. But this is very complex data, and there's a lot of groundwork, a lot of legwork necessary up front to make them successful.
And one thing I'd like to point out with this is that, and it's probably a theme that that's run through kind of everything we've talked about today, and that's treatment. We are really moving in genetics into the realm of using diagnostics for very specific treatment aims. If you look at the history of genetics, we were able to diagnose Down syndrome, which is terrific and important, and it does have implications for how you manage those children. But for many of the molecular tests that we're talking about today, if you look in the realm of pharmacogenetics, you look in the realm of cancer, if you look in the realm of highly specific treatments in newborns. We're talking about using the molecular test to tell the physician and the patient something very specific about them, very tailored, very narrow, which makes both patients and physician providers very excited, because this is what they've been asking genetics to do for the last 40 years. Give us something in the genetic test which tells us exactly what we need to do. Now, obviously with pharmacogenetics is just one piece of the puzzle. But if you think about, for example, depression, there are a number of classes of medications you can use. There's SNRIs or SSRIs. And if you have this pharmacogenetic information, you can better choose an antidepressant or an anti-anxiety medication from the get-go, rather than having to try 2 or 3 different ones. And so I think that's the theme, and that's the reason why genetics is becoming more and more successful today, because physicians can actually jump in and say, aha, this is the medicine I should be using for this patient.
Great point. Great point. Those were all very good. And so when talking about precision medicine and specific to clinicians, that's partnering with certain groups, it's having some send out partners, ordering these tests, but specific to health systems, it can look a couple different ways. So one path is where you've got a health system that's a little bit further down this path, and they want to purchase sequencers, and they've got expertise there where they're going to stand up their own program. And then there are groups who might want to get to that point at some point, but they're not there yet. So they want to start ordering these tests. So they want send out partners. One of the key things that groups want to think about is, how do we limit the number of send out partners? So you're going to have different clinicians ordering from different groups. And that's good. It's good to have several different groups, but you want to limit those as much as you can. You don't want to have 15 different, precision oncology partners, 7 different pharmacogenomics, and several others for neonatology. If you can find groups that can offer all of those or some of those, you're going to be on a better path. Also, for health systems that do want to get on that trajectory towards standing up their own program, a lot of health systems are starting to realize that there is power and there is value in their data. So different groups that you'll work with, some of them will own that data. If the health system wants to own its own data while they're kind of building that, even if you don't know exactly what the value of that is yet, but you want to build that, leverage it later, that's a question that you need to ask early on when you're starting to talk to send out partners. So we covered some of those barriers. I do want to talk about, kind of beyond the testing. Devin, what do you see as the next big challenge of making this a little bit easier? Is it getting everything into the EHR? You touched a little bit about, that clinical decision support.
Yeah, I think the data is key in many respects, right? Genetic data is different than other laboratory test data in that it's relevant for the rest of your life in many cases. Obviously, maybe that might not be the case with tumor sequencing, but certainly any germline DNA sequencing or testing isn't just relevant today, it's relevant for that patient for a long time, for the rest of their life, right? So, and we're still learning a lot. The knowledge base on which all of these clinical decisions are made continues to evolve. So to your point about data, one of the things that's important is that that health systems retain some rights to their data so that they can contribute to the advancement of that knowledge base. If they are giving their data away, then who knows where the data is going to land and who has rights to leverage that data. So I think that there's been a push to sort of retain data rights within the health system so that they can both keep it and leverage it, but also can participate in analytics and the science to advance the field. And you can only do that if you have access to it and you know how to work with it. And then that's also true on the patient side. So if you're a patient and you've got some genetic testing, in the ideal future, you should be able to take that with you throughout the rest of your life. And your physicians should be able to access that clinically valid data and reinterpret it based on the latest knowledge base of information, the latest science, and act on it. And to do that, we need the infrastructure such that people's genomic data is kept in a, obviously a secure, HIPAA compliant manner with labs that have generated it, and also make it portable and accessible to the patients so that they can hand it off to their physicians, and physicians can order new analyses of that data in the future. So we're building platforms, one in particular, Genome Gateway, that's going to enable that, very a patient-centric, really a portal, if you will, but one that's also engaging. It has education, and it also has this concept of data ownership and communication with one's physician about how your genomic data is being used clinically. So those are the kinds of things that I think are the future hurdles that need to be accomplished. Like you said, how you push the data into the EHR, how you trigger clinical decision alerts. To me, it's still going to be more than just a flag that shows up in the EHR. It's a comprehensive solution that needs to be engaging with consult and all sorts of other things. It's not just going to be an electronic button or flag that shows up. It's got to be more than that if this is all going to be successful.
Right. Clinical decision support can mean a variety of things. With software, sometimes it is just a button and it's, that flag, but we try to take things beyond that level. Sometimes it's phone a friend, it's case review, it's really going over everything to make sure that our clinicians understand exactly what this means until they get comfortable and more used to this, because it's really shifting gears and looking at things in different ways. So with that, I think we're about out of time. So Devin, David, thank you both for sharing your insights when it comes to transforming treatment with precision medicine. It's something we're clearly passionate about and believe should be accessible to everyone, not just those that happen to live in big cities or close to those large academic medical centers. So Mark and Russ, thank you again for having us at Health Connect South again this year. We look forward to hearing some other wonderful presentations and also returning next year. So with that, we will sign off. Thank you all.
Bye-bye.
Bye-bye.